Let's talk about a kind of hip pain that is so tricky to pin down. You know, the kind that often gets missed or misdiagnosed for months, sometimes even for years. It's this deep, nagging ache that just doesn't seem to fit the usual script.
I mean, does this sound at all familiar to you? A pain that's way deep in your gluteal area, maybe it even radiates a bit, and it just screams at you when you try to lengthen your stride or after you've been walking for a while? If you've ever felt that, you know exactly how frustrating it can be.
Well, you are definitely not alone. So today, we're going to get into the science behind a very specific condition called ischiofemoral impingement, or IFI for short. And we're going to use a major medical review as our guide to really understand what it is, and more importantly, what the best evidence says about how to treat it.
So what in the world is IFI? Okay, here's a good way to think about it. Imagine a door that can't quite close all the way because something's jammed in the doorway. In this case, that something is a muscle deep in your buttock called the quadratus femoris. The door frame is your pelvis, specifically your sit bone, and the door itself is your thigh bone. When that space gets too narrow, the muscle gets pinched, and bam, that's where that deep, hard-to-describe pain comes from.
Now, this is where it gets really interesting. Who does this condition usually affect? The medical review we're digging into found a pattern that is just impossible to ignore. Just look at this number, 91%. What do you think that refers to? Yep, the big review we're looking at gathered data on 101 patients from 7 different high-quality studies, and a staggering 91% of them were female. The researchers think this could be tied to basic anatomy. You know, women on average have wider pelvises, which might just create a tighter squeeze in that area, making them more likely to develop this kind of impingement.
So if it's so prevalent in one group, how do doctors actually figure out that this is what's going on? Well, it's not quite as simple as a single blood test or X-ray. It's more like being a detective.
Clinicians have a really smart 3-step process. First, it starts with a physical exam. They'll have you do specific movements, like a long stride test, to see if they can reproduce that exact pain you're feeling. Second, they'll bring in the heavy machinery, an MRI, to actually see the pinching happening inside. And third, and this is the really clever part, they might use a diagnostic injection. They inject a bit of anesthetic right into that spot, and if the pain just disappears, even for a little while, that's a huge confirmation they found the culprit.
So when they look at that MRI, what are they searching for? Well, it's 2 key things. First, they can literally see that the space for the muscle is much smaller than it should be. It's visibly narrowed. But then they also look at the consequence of that pinching. They look at the muscle itself, and they can see signs of distress. They might be swollen, or in really long-term cases, it might even start to shrink from all that constant pressure. These are the visual clues that scream IFI.
Okay, so you've got the diagnosis. Now what? What can actually be done about it? This brings us to the real heart of the scientific review we're looking at today. What does the evidence actually say about the best ways to treat this?
Now, before we jump into the results, it's really important to understand where this info comes from. This isn't just one doctor's opinion or a single small study. It's from something called a systematic review. And that's a huge deal in the medical world. It's where scientists basically collect all the best, highest quality research on a topic and then analyze it all together. It's considered one of the strongest forms of medical evidence out there.
And this just shows you how intense that process is. The researchers started with a mountain of data, more than 700 scientific articles. Then they started filtering. They used this super strict process to weed out any duplicates, studies that weren't relevant, or research that just wasn't up to snuff. They whittled it all down to just the 7 most solid, most reliable studies on the topic. That's how we can feel really confident in what they found.
So, what did those 7 studies show? Well, it pretty much boils down to 3 main treatment options. First up, you've got those image-guided injections. They're fantastic for confirming the problem and giving you some quick relief, but that relief is often temporary. Then you've got a minimally invasive surgery called an arthroscopy. That's where a surgeon carefully shaves down a tiny piece of the bone to physically create more space. That showed really consistent, long-lasting improvement. And finally, for more complex cases, there's open surgery, which also had great results.
Let's just zero in on those injections for a second, because the data tells a really interesting story. Right off the bat, an impressive 85% of patients felt immediate pain relief. That's awesome for diagnosis. But look what happens over time. Just 1 month later, only 58% were still feeling that relief. So what does that tell us? It tells us injections are a fantastic diagnostic tool, but for a lot of people, they're probably not the long-term answer.
So for that more durable solution, the evidence really points toward surgery. And I'm just going to read this line because it comes straight from the study's own summary, and it's pretty clear. It says that the minimally invasive procedure led to consistent improvement in hip function and return to activity with minimal complications and revision rates. That is a very, very promising conclusion.
So, after looking at all this evidence, what's the big picture? How do you turn all this research into a practical game plan for someone who's actually dealing with this pain? Well, the review pulls it all together into a really logical pathway.
The evidence really suggests a step-by-step plan. You start with the fundamentals, a good clinical exam, and that all-important MRI. Step 2, you use that image-guided injection, both as a final confirmation and to get some initial relief. Then, if the pain comes back and just won't go away, Step 3 is to start thinking about that minimally invasive arthroscopic surgery. And finally, open surgery is kept in reserve for the most complex cases with other structural problems. It's a really clear progression of care.
All right, let's boil this all down. What are the key takeaways you should remember? First, ischiofemoral impingement is a very real condition that probably flies under the radar way too often. Second, injections are a critical tool for nailing the diagnosis. Third, for people who need more than temporary relief, surgery looks like a very safe and effective long-term solution. And finally, and this is super important, while the evidence we have is really promising, it's based on a small number of studies. We definitely need more research to build on this great work.
And that really just leaves us with one final thought to chew on. Not too long ago, this was a condition that almost nobody had ever heard of. But as our technology gets better and better, as tools like MRI let us see the human body in more and more detail, is it possible that this mysterious hip pain will one day become just another routine diagnosis? It's pretty interesting to think about.